Okay, good morning, everyone. It's very exciting to have everybody here. I see a few people who are good friends who will be talking with us today, and I'm very excited about this agenda. I'm going to get us started quickly with an overview. First of all, thanks to Elena Wynn and the organizers of at the California HIV/AIDS Policy Research Centers in taking on this issue about ending the HIV epidemic regional meeting, taking strategic action to address substance use in California. This is the first of 2 days. I want to start us by thinking about the coexisting epidemics that intersect of HIV, addiction, hepatitis C, and other epidemics as a setup for the pandemic. And it also gives us a rationale for this regional response that we're arguing for. First of all, for about 80% of us out there, the standard biomedical and behavioral and risk reduction approaches to HIV care and prevention are effective, but the remaining 15 to 20% require tougher decisions about how to manage their disorders. At the same time, we have an erosion or unavailability of health resources that are fuel. This is unprecedented times when the threats to healthcare and the erosion of availability of healthcare is an ongoing concern. There's heat from substance use and mental health disorders. There is oxygen from poverty. And when you bring all these three things together, what you get is a fire, an outbreak. You get this ongoing intersecting epidemic thing. And when you add COVID-19 to this, it becomes almost nuclear in its effects in terms of exaggerating the concerns that we have to deal with. Today, we're going to focus about substance use, and we're going to discuss the current state of substance use and how it contributes to the HIV epidemic and related syndemics. In California, we're going to identify multiple strategies to address substance use in California, and we're going to discuss action steps. We want to be focused on thinking about regional responses that policymakers, advocacy folks, program people, and research stakeholders can use to move strategies forward over the next 12 months. We're not going to stand by and wait for people. We're moving forward, folks. That's what we're going to do. Thanks for everybody for your enthusiasm in helping to make this happen. Here's the agenda for today. You can see I'm going to give us a little bit of an opening remark, and then Elena, our organizer, will take over and introduce the day. I want to give us a couple kind of hair-raising, hair-on-fire facts that are ongoing right now. Chelsea Shover, our own Chelsea Shover from UCLA, published these data this week. She wasn't waiting for the fentanyl data, so she went throughout the Western U.S. Health departments from the West and was looking at the fentanyl overdose deaths between 2016 to 2020. Usually we don't have 2020 data. She went out there and got these data herself and published them. And you can see here that lag mortality rates in percentiles, particularly in San Francisco, is hair on fire crazy. Here is the lag mortality rates in the East Coast, which is really bad. And what we see here is for the first time, places like Los Angeles County, King County, Washington, having high rates of fentanyl overdose deaths. Folks, we got a problem. This is a really serious issue that's hitting Los Angeles, and it's, you know, it's terrible. When you look at the other drugs that are involved with fentanyl overdose deaths, one of the things we see over the past few months here in 2020 is the increasing rise of the popularity of cocaine. Methamphetamine continues to be high throughout, but you can see here that this is what's happening along this way. A resurgence here of prescription pain pills, just sort of crazy. And you can see that heroin has almost all been dropped out of the overdose deaths that are linked with fentanyl. So we called a meeting for Thursday morning. This is something that will happen at 9:30. You're all invited. I would encourage you to attend. Chelsea Shover will be talking about the study more in depth. And Philip Coffin, who's at the San Francisco Public Health Department, will be presenting action items that he has found helpful in terms of addressing fentanyl in San Francisco and the increasing amount of overdose deaths that's going on there. The meeting link is here. The dial-in number is here. And I encourage you all to please take time to take advantage of this moment to be able to get better in terms of moving forward in action items. Okay, enough. So, okay, let's get organized. Today, we have technical assistance on the line, Pacific AIDS Education Training Center, the Pacific Southwest Addiction Technology Transfer Center, the Technical Assistance Provider Innovation Network, and 2 NIDA-funded projects, and you can read as well as I can read. In terms of opportunities to engage today, there will be the fentanyl meeting. That's going to be in a couple days. We're going to hear about Project HPTN 094, an information session on October 26th. And we'll have the day 2 of this End the HIV Epidemic regional meeting. I want to welcome everyone. It's awesome to see everybody here. I'm energized to see this continuing interest in the regional response. I want to turn it over to our capable and very good leader, Elena Rosenberg Carlson, who will introduce the next speakers.
Thank you so much, Steve. Good morning, everyone, and thank you for joining us today. Before we move into our first panel, I just want to note that you are welcome to share any questions or comments that you have in the chat at any time throughout today's session. And we'll also have a brief period for live Q&A discussion at the end of each panel. And if you'd like to submit any questions for the live Q&A, please just send those over directly to Craig Pulsifer. So Craig Pulsifer will be collecting those questions for the live discussion. I also just wanted to mention that we are recording both meeting sessions, and the recording and meeting materials will be posted on the CHIPS website after the second session next week. We have 2 great speakers for our first panel today on substance use in California state and community perspectives. We'll begin with Alessandra Ross, who's the Chief of the Harm Reduction Unit at the California Department of Public Health, Office of AIDS. Welcome, Alessandra. I think, there you go.
There. All right. Thanks very much. I'm really grateful to the organizers for putting this together and happy to be here. I'm looking forward to what the conversation produces. This is really vital. I'm going to talk about the interlocking and overlapping epidemics of HCV, overdose, and HIV. Those are just 3 of the ones that we need to grapple with. And with the caveat that my primary area of expertise is that I'm a policy analyst. So as I present this data, if there are errors in it, it comes from me messing around with my slides and not from anything that the original folks who put the data together did. And I want to just start with there we go. Okay, will not let me advance there. Just celebrating some of our successes is that we have already reduced the share of HIV infections that are attributed to injection drug use by a significant amount. CDC estimated that in 1990, fully 40% of all cases of new HIV were among people who inject drugs. Now in California in 2018, 8.1% of new HIV cases were among people with injection drug use transmission risks. So that was a tremendous and early success. And the consensus in the public health field is that that's attributable to syringe services programs. Not only have we been very lucky in California to have had these programs since the late 80s, they provide sterile injection equipment so that people don't have to share or borrow or reuse their works. But they also do something that unfortunately is still really unique, which is that they work with people while they are continuing to use drugs. And that is still unusual. It is still unusual to have that commitment be central to an organization's mission. As we all know, usually if you let somebody know that you use drugs or it is somehow revealed that you use drugs, the welcome mat that was put out is just whipped back in. So having that to be core to the mission, treating people with love and respect, are part of the core principles of harm reduction. And those don't have to be done just by syringe services programs. There's tons of programs that can and do embrace not only those principles, but also the principle of treating people who use drugs as experts who can guide us in shaping policy and programs. So when we take a look at California in the last 20 years, I've picked 2002 for the map of old California because it was the year that Alex Kroll and Ricky Blumenthal were finishing up their CalCEP study. They looked at the then 35 programs in California and described this as a patchwork approach to authorizing syringe services programs. And you can see that most of the authorized programs are on the left coast. So those were progressive governments that had the authority to allow syringe services programs and were responding to the AIDS epidemic. Now in 2020, up from 35 programs, we have 60 programs. And part of the way that that was able to happen was that HIV advocates, drug policy advocates did their work and advocated for a change to the law to allow authorization not only by local governments, but by the California Department of Public Health. And the programs that we've been authorizing in the last 5 years are not responding to HIV, they're responding to the overdose crisis. So we are all aware of the massive increase in opiate overdose deaths. Researcher Dan Ciccarone's described this as a triple wave, starting with pills in the 1990s, the next wave being heroin, and the current wave, fentanyl and fentanyl analogs. We also have a very deep and committed relationship in California to methamphetamine. And in 2018, deaths related to methamphetamine overdose overtook deaths related to heroin overdose. And that is the first time that that's happened. So I'm really looking forward to the methamphetamine conversation. Let's see what's happening here. See if I can get my slides to go the correct direction. There we go. So that methamphetamine increase was 212% from 2012 to 2018. Drug-related deaths due to opiates seem to be on the rise nationally. Josh Katz estimated that in California, there's already a 23% increase in overdoses during the COVID-19 epidemic. And overdoses and hepatitis C have been rising together, especially among young people. So hepatitis C chronic cases, newly reported cases increased 159% from 2012 to 2016, and that was very similar to the heroin overdose death increase between 2012 and 2016, and that's continuing, and it's a national trend as well. So here you see the age distribution of hepatitis C. 2007, this was really a middle-aged disease, people in their 50s and 60s who might have had an injection past in their 20s being diagnosed with chronic hepatitis C. And now we've shifted to a bimodal distribution with that two-humped camel, and the first hump being chronic hepatitis C cases among young people age 15 to 29. So 2015 was also the year of the Scott County, Indiana HIV outbreak. More than 200 cases of HIV were diagnosed among people who were sharing contaminated injection equipment in this very small rural area. Something that we don't always talk about was that HCV was also present. Most of those folks were also infected with hepatitis C, and that increases in 20 to 29-year-olds preceded that HIV outbreak in Scott County. And that's something that's being seen in other outbreaks since 2015. This slide comes from a CDC health advisory that they put out earlier this month. And I'll put the link to that in the chat because it's really helpful. It includes a link to a manuscript in which they evaluate several of these different outbreaks. What did CDC do in response? What did the state and local health authorities do? And what lessons have they learned? And it includes some really helpful policy recommendations that I think this group and I have found really useful. So I think most of these next couple of hours and tomorrow we'll be talking about gaps and opportunities. And I just want to throw out a couple of the ones that to me seem salient and the ones that we're sort of paying attention to at the State Office of AIDS. One is to continue to expand syringe access. In Los Angeles County, there's been one new program in the last 15 years. And so I think it's worthwhile thinking about whether or not a program is the best way to expand syringe access. Are there pharmacies can sell syringes without prescription, physicians can provide them or they can prescribe them. There's a mail order program, there's street medicine. So how else can this be done in a way that kind of goes around whatever the barrier is to creating a program? How can these services be more integrated into what already exists for folks? Another idea that we're looking at almost all the time is to examine the funding streams and look at who's been left out. There's a long legacy of that comes from the federal funding banning syringe services programs. So all these little policies and procedures are still in place. People know now that they can use CDC funding to support syringe services, but do they know that they can use HRSA funding? What are the barriers to using SAMHSA fundings and to including syringe services programs in the family of drug treatment programs? Expanding access to medication for opiate use disorder, super exciting developments that I'm sure we'll be talking about more. Telemedicine, take-home dosing, all these initiatives to expand buprenorphine and make buprenorphine just as available as heroin. That is a fantastic initiative that's ongoing and can use even more push from all of us. Improving viral suppression for people who inject drugs. Viral suppression for people who inject drugs is incredibly poor. 2018 data shows only 50% of people newly diagnosed achieved viral suppression. So what can we do in that area, which leads to rooting out stigma and mistreatment? I think one of the things that harm reduction programs regularly do, and you all do too, is when you give a referral to another service, you know whether or not that organization is going to treat your folks well. And you have verified that. And if we think about how painful that is, that we always are checking and we're always searching for the safe and empowering place that we can send folks, and sometimes there's nowhere. So what can we do to expand our options and the options for the people that we work with? And then lastly, just continuing the idea of nothing about us without us, treating the folks that we serve as experts in their own experience and experts that can guide us to ending the HIV epidemic, I think are some of the guiding principles that we can look to over and over again to reaffirm the work and to make genuine progress. So with that, I will pass it over or pass it back to Elena and our next speaker.
Great, thank you so much, Alessandra. Next, we'll hear from Jenna Haywood, who's the Associate Director of Community Mobilization for the Harm Reduction Coalition. Good morning, Jenna.
Good morning. First, I have to apologize if you can hear my Chihuahua barking in the background. He sleeps all day long, but of course, he decides to just bark his head off right as I am up to present. So I tried to put him in the bedroom. I hope it's not distracting. So my name is Jenna Haywood. I work with the National Harm Reduction Coalition. I'm the Associate Director of Community Mobilization. And I have the honor and privilege of working with all of the syringe services programs throughout California and other harm reduction providers as well. A little bit about National Harm Reduction Coalition. These are the 5 buckets of work that we do. A few years ago, we adopted a North Star statement that we use to guide all of the work that we do today. It says, National Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms caused by racialized drug policies. And for us, it's really important to have all of our work grounded in the fact that, yes, there are risks and harms that are associated with drug use itself, but that there are far more harms caused by drug policies. And to explicitly name that the war on drugs and drug policies are racist and affect BIPOC folks most drastically. So I'm just going to talk a little bit about the brief history of harm reduction.
Jenna, I'm
Yeah.
so sorry to interrupt, but I don't think folks can see your slides.
Oh, you're right.
Want to make sure to have those great slides up
So I
there.
didn't, so let's see. Yeah, my slides look really good, so I want you to see them.
That's right. We're all waiting for them.
Can you see those now?
Yes, thank
Okay.
you.
So these are the 5 buckets I talked about. You can glance at really quickly. We do have a brand new website, so I would encourage everyone to check it out, harmreduction.org. We have, it's a lot more easy to navigate, and there's a lot of great resources on there, including training materials, handouts, publications that can be really useful in this work. So I'm going to talk a little bit about syringe access in California, although I will be the first to say I am not the right person to really give you a deep dive into the history of harm reduction in California. There are others who you'll hear from and who you've just heard from who know a lot more about that. But to kind of bring us to what it looks like in the present day, and then to look at some of the current barriers to services and what are things that are happening or organizing opportunities for change. So as Alessandra talked about already, syringe services programs have been around a long time. They've played a central role in dramatically reducing HIV infection among people who inject drugs. And there are decades of evidence to support the benefits. And I think that's something really important for us to keep in mind, is that there is no shortage of evidence showing the benefits of syringe services and of harm reduction, and yet there's still challenges to it. And so where does that come from if it's not? What are the other ways to reach people if we can't do it through data and evidence? And so some of the other benefits of harm reduction programs are, not just reducing HIV infection, but also other infectious diseases like Hep C and B, skin and soft tissue infections, and other health conditions. And that includes actually being a really vital response to COVID-19. And there's just been, I guess it's no surprise that programs that dealt with an extremely stigmatized infectious disease back in the 80s would be well suited to deal with emerging new epidemics. And so that's a really important point as well. And so Alessandra talked about it. They provide tools and services, but really so much more, using the principles of meeting people where they're at and focusing on health and well-being over cessation of drug use. And so that's so key, and something that Alessandra mentioned as well. These are some of the different tools and services you might see. I want to point out that syringe access and disposal, we often think of as one service. So when we talk about syringe exchange, we think of you exchange a used and you get a new. And actually, thinking about those two things as separate strategies is really where things are moving, because it is important that someone have a sterile syringe for every single injection. And so even if they don't have one to return, they need to have one, they need to have, enough for every injection. And so that means that sometimes if they're not bringing them back, what are strategies, what are opportunities for disposal that are outside of an exchange model? There's safer drug use supplies, including fentanyl test strips, overdose prevention like naloxone, condoms have been a big part of it, and other safer sex materials. medication for opioid use disorder, safer consumption services, which I think we'll hear about a little bit more later today. The housing first model, so that's looking at, housing as such a critical need for so many people who are experiencing drug-related harms. And it's actually been fascinating to see how during COVID, we've been able to suddenly adopt housing first models that were said to not be possible before. And referrals. Harm reduction programs offer linkage and navigation to services and to care. And they're really a point of entry into so many different healthcare opportunities. These are just some photos. I didn't put the credit on here, but to show that syringe services programs can be out of the back of a car. They can be in a mobile setting, like a table that you see there. They can be out of an RV and out of a backpack, or there's fixed sites like on the lower right-hand corner, which is inside of a brick and mortar building where it would be a location that is fixed. So as Alessandra said, syringe services have grown a lot. I guess there's 60. It's actually been hard to keep up with how many because we've seen such a huge growth. And since 2016, they've expanded to 15 new counties. And mostly those counties have been rural places outside of the coast where, and looking at the, where, the 8 counties that that end the HIV epidemics focuses on, there has been expansion into those into those counties that are at high risk for big outbreaks. And so we've seen actually where it says the orange is where they're expected to start. Every single one of those has actually started. I just haven't updated the map with the exception of one. And as they've opened and as we've had more expansion, there's been an increase in new participants. This data is a little outdated, and so it's grown even more. Programs are seeing a demand, they're seeing more participants, and they're seeing an increase in demand for supplies, and that's continued to happen during COVID. So, that leaves us, if we have all this growth and there's all of this access out there, then why are we having this conversation, right? You would think that we have the solution. This works. Let's just do it everywhere. No big deal. Well, unfortunately, there are barriers that continue to impact accessibility of services and programs to offer services. And so, I'm pretty sure if you talk to people who have been doing this work a long time, people have experienced opposition forever, and kind of not in my backyard type folks coming out and saying, this is enabling, we don't want you here. But it does seem to have become more intensified. And I really do think that it has to do with it's expanded, it's becoming more popular, it's becoming more accepted. That means that people who use drugs and people who are normally left out are actually having their rights considered, and they're gaining power and momentum. And the status quo doesn't like that. And we see so much divisiveness in the country, and this is an area where that is really evident. And so you'll see this is actually current campaign literature for a city council member, Sean Morgan out of Chico. He's advertising that if you vote for him, he will create needle-free streets. So that is his campaign slogan. It is a base building issue for right-wing candidates and groups throughout California. And that is really scary. And it tells us that stigma and xenophobia are alive and well. It makes it hard for people to not only operate services, but people who need to get supplies and services are not going to want to go and go to those programs, even if they do exist. And so it's a real barrier. We also continue to see criminalization of people who use drugs for drug possession, but also for syringe possession, which is legal under AB 2077. And yet, when we scan programs, they're seeing citations that lead to warrants, that lead to arrests, that usually get thrown out in court, but yet that person's life has already been disrupted because they've been harassed and for having syringes. It also doesn't, it's also not going to make it possible for them to hold on to their supplies in order to have that new syringe for every single injection. We hear a lot about, people their stuff being taken and thrown out. But it's not everybody. It's people who are poor, people who are unhoused. It's trans folks, it's Black, Indigenous, people of color living outside specifically. So this is not about, it's not just about the drugs. It's about targeting people who are already experiencing systemic oppression. And then there's a supply shortage as well. So the Clearinghouse Supply Fund, which was started in 2015, it's $3 million that the Office of AIDS gets from the state to pay for supplies to programs across the state. It stayed at $3 million since 2015, and I showed you that map of all the growth. So it's not enough money to provide supplies for everyone. This year, 75% of programs said they're not going to have enough to get them through the year. And so that means that they're having to ration, and it means they're not able to comply with best practices, which is a needs-based model. So making sure that people have what they need. And then there's still gaps in areas covered. There's, even if there's one program in Riverside County, for example, Riverside County is huge, and it's one program may not be able to reach everywhere. There's geographical barriers. And so without funding for more staff and more supplies, programs are not able to really do everything they could. So that paints kind of a bleak picture, but I want to end on a positive note. And I know that there's going to be more talk about strategies and stuff next week, but I couldn't, this is such a big part of what I do every day that I'm, wanted to share it. So there has been a network of syringe services programs for years in California, and we've just been building on that and expanding that. It's called the California Syringe Exchange Programs Coalition, or KSEP. It's a mutual aid and advocacy network that that shares knowledge, best practices, and that where advocacy for policy that advances the rights of people who use drugs can happen. And so one success story, and this was done in partnership with Drug Policy Alliance and other folks who have been doing policy work for many years, but the programs themselves who are part of KSEP were an integral part of going to the state legislature with some of these concerns and actually getting $15.2 million allocated into last year's budget for staffing and for staffing specifically to address needs for navigation into other services. And so, that was an example of how interconnection is our strength. And how, again, if we already have so much data and evidence, and so if we need to look outside of siloed work and really, when the word syndemic is becoming more popular, and I think it is so important to think of all of this stuff as happening together and to look at how harm reduction programs, don't just need to be syringe services program. Harm reduction should be integrated into any kind of healthcare setting. And we've seen some barriers broken because of COVID. We've seen people start to work together. Our different harm reduction programs have been invited to sit in local and county-wide task force and committees around reimagining public safety, because harm reduction programs are already alternatives to policing, alternatives to law enforcement interaction, to jails and prisons. They already know how to de-escalate conflict. They know how to meet people where they're at. They know how to provide care, and they know how to build trust, which is so key to really creating change. So, and in COVID-19, we've seen, people get into housing who could not get into housing before. We've seen methadone take-home doses be possible, telemedicine for Butte be possible, all of these things that, again, there were just kind of artificial barriers set up. And we're seeing more collaboration across movements. So I've been a part of the End the Epidemics Advocacy Coalition, and we've been meeting with all of these different experts from intersecting fields and movements to come together to talk about how to deal with this stuff in California. And so I saw in the chat, somebody said, how can we support you? Absolutely. Harm reduction programs need all the support they can get. And they would love to have people come out and visit and see what their site's about, talk to them what they do, talk to them about areas for collaboration. And so I'll just end with this final slide. When we talk about harm reduction, not just being tools and services, but also being a philosophy and really a movement. And so thinking about public health as social justice and thinking about how we can combat racism and stigma and marginalization and criminalization that are really what causes harm, not drug use itself. And how we can understand and work together, and understand the interlocking struggles against inequality and oppression that are central to both health and liberation. And lastly, and Alessandra, you talked about this as well, but really making sure that in order to do all of this, if we have questions about how it should be done, then that means we need to be inviting people to the table who are most impacted by these harms, because they know what they need and they know what they don't need. And so really thinking about how can we bring and uplift the leadership of people who are most impacted by structural oppression. So thank you so much. It's my email there, and that's all I have.
Thank you so much, Jenna. So now we'll move into some live Q&A discussion with both Jenna and Alessandra, and we've gotten a couple of questions already coming into Craig. So we'll start with a question that says, do we know the places in California that are most vulnerable to HIV, HCV, and overdose that don't have authorized syringe exchange and other harm reduction services? So Alessandra, I don't know if you might be able to comment on that.
Yeah, I think, well, I believe my colleague Rachel McLean is on the line. We are currently finishing up a vulnerability study that was inspired by the vulnerability study that CDC did some time ago, where they identified individual counties in the United States that had an elevated risk for HIV or hepatitis C. And CDC then funded states to do a very similar vulnerability study and also include overdose. So Rachel, do you want to talk a little bit about where we are in terms of progress with that? And Rachel is the Office of Viral Hepatitis Prevention for the California Department of Public Health. Yeah, I'm sure there's a better title than the office, but I'll let you take that over, Rachel.
I am an office.
You are.
I'm not a person. Hi everyone, I'm Rachel McLean. I'm the chief of the Office of Viral Hepatitis Prevention. Although I have been thinking about the word chief and wondering, should we really be using that word in government? That's a separate conversation. Good morning, everyone. So yes, we were funded by CDC to basically replicate the analysis that they did at the national level, identifying which counties are most vulnerable to a rapid increase of HIV, Hep C, or overdose related to injection drug use. We actually shared the findings with local health departments last Friday. We've been putting this on hold due to COVID because local health jurisdictions are just overwhelmed. But we shared the findings last Friday with HIV, STD controllers and communicable disease controllers at the local level. I have a presentation scheduled for November 5th for local health officers. We're giving the data to the counties and giving them just some time to absorb the information before we release it publicly. As you can understand, health departments are pretty overwhelmed with COVID right now. But I do have a presentation scheduled with the Epidemic Coalition, California Hepatitis Alliance, California Syringe Exchange Programs. We're going to be sort of making the rounds to share the findings with the community and talk about sort of what they mean and how to use them. and just to be really honest, like as far as I'm concerned, and I think Alessandra and Loris and my other colleagues at the California Department of Public Health, we all feel like the purpose of the analysis is to really to show the unmet need for truly scaled up harm reduction services in California. And, you know, the sneak peek of the findings is that all communities are vulnerable and all communities need harm reduction services. Some are more vulnerable than others, but all of them are vulnerable. So that's the sort of sneak preview, but we will be sharing the findings with the community in November.
Great. Well,
And
thank you.
Ryan Clary, we just put it on the calendar. I'll look at my calendar and put it in the chat what the date is, but we just scheduled a presentation that everyone is welcome to attend.
That would be great. Yeah, and Rachel, if you want to send that along to me as well, I can include it in the email to participants afterwards. Wonderful. So thank you both, Alessandra and Rachel. For our next question, intermittent drug use is very common among men who have sex with men. How can harm reduction services better reach this community? So Jenna, would you mind taking a crack at that question?
Sure. Yeah, I mean, I think that's a really great question. And I think one of the things, a couple things, one is again that, you know, harm reduction programs, we should think of how we can bring harm reduction into all other services versus how we can get people who might not fit into a specific population, like might not be an injection drug user, to go to a syringe services program. So that's one thing. But also we've seen the expansion of supplies that are offered. So a lot of programs are now offering smoking pipes, as well as some offer snorting kits. And so yes, those are helpful in reducing infectious disease spread, including COVID, right? People should not be sharing pipes with COVID. They should not be sharing straws for snorting equipment. You can get fentanyl test strips there as well to test stimulants to make sure that they don't have fentanyl in them. But it also means that more people are getting to have a touch point of care. So even if there's, you know, no disease prevention aspect, there's still so much more that can be offered by just having the contact with the program.
Thank you, Jenna. So I think we have time for one more question, and then we'll add any other questions that were submitted to the chat, so Alessandra and Jenna can take a look at those there. But for our last question for this live Q&A, how can counties that are more permissive of syringe service programs work with neighboring counties that are less permissive? And how can we help expand the syringe service programs in counties that are not as happy with this approach? And that question is for either or both of you.
Well, let's both do it. That's a great question. And I think Plumas is really a model for expanding what they started to the surrounding counties. And the way they did that was through their opioid coalition and through bringing other people into the joy that is harm reduction, so that everybody caught the fever and started loving talking about drugs and talking about drug use and having those frank conversations and starting programs. So it was a really interesting process to watch how they did that unfolded over several years, so that it was that building relationships. And so I think for most health departments, it's looking at where you already have those relationships, where are you already regularly meeting, and how can you show what you're already doing, why you're jazzed about it, and what the fantastic results have been for you, whether or not you're doing like late night outreach to a stroll or starting a syringe service program. Regardless of what it is, it's the enthusiasm and the joy with which you talk about your work that brings other health departments in. Yeah, that's my take on it. But Jenna, you probably have a slightly different one.
No, I mean, I definitely agree. I think relationship building is really the key and the foundation to good organizing. And so figuring out, you know, looking at who it is that may be in opposition and why, what's going on for them, what is their motivation for being so against it, and then looking at who's the person that can move them into a support role. And so health departments, neighboring health departments, people who, we'll go and say, look at in San Francisco, XYZ. Well, people in rural communities don't want to hear about San Francisco. And so you have to think about who is going to be able to kind of speak their language, and the power of storytelling is so huge. Again, there is a place for data. It's super important, but also, when we were in Chico at the city council meeting, the whole city council just said, I don't care about data. I don't want to hear it. I don't care. I don't care how much evidence there is. We're not doing this here. This is not the Chico we want. We are going to take it back to restore it to, a previous state that is, really, I could go into that longer, but anyway, yeah, so I think that's a big part. And then in terms of just like logistics, programs also have gone right up to the border of another county to help participants get access by actually, getting closer to where they live. And people have been doing that for forever, mutual aid, sharing, helping each other with supplies and resources, and making sure that people have what they need well before it was, sanctioned. So
That's a good example of where data does matter. If I can show the zip codes and say, I'm serving your folks. Would you like to serve your folks? But I agree, it's data is necessary, but insufficient, right?
Thank you both so much. Thank you for this great discussion and also for your great presentations. So now we're going to move into our next panel on strategies to address substance use. And we'll begin with a presentation on evidence-based interventions from Dr. David Goodman Mesa, who is an assistant professor in the Division of Infectious Diseases at the UCLA David Geffen School of Medicine. Welcome, David.
Thank you, Elena, and thank you to the members at CHIPS for inviting me to do this presentation. As you mentioned, I'm an infectious disease doctor, and I really see the downstream harms that people who use or inject drugs face when they do get an infectious disease. So I get the kind of boring part to go through the science and multiple graphs. I'll try not to make it as cold as it can be, but bear with me. So I do this talk, or a very different talk, for the doctors here at UCLA and many other medical centers here in Los Angeles regarding substance use and the different services that we could provide to help people who use drugs. And really, doctors, I think, in many ways, we're really far removed from this population, and we really are part of, in many ways, the problem related to stigma when individuals who use drugs really face medical establishments. So this is a cheat sheet that I present to, say, the medical residents when I do these talks. And these are all the interventions for the doctors to consider or know about when dealing with somebody who uses or injects drugs, and especially opioids. But I think they're really applicable in any setting where we provide services to people who use substances. For people living with opiate use disorder in particular, we actually have effective medications. We have 3 medications that are FDA approved: methadone, buprenorphine, and extended release naltrexone. I'll say it now, detox is something that does not work. Close to 95% of people who undergo detox relapse within 6 months. I listed here due really to the social stigma and myths around medications for opiate use disorder, as patients and family members still request these medically assisted detox. Even though for many, the ultimate goal is recovery, many individuals are really not ready in their drug use trajectories, or if recovery is achieved, they're always at risk for relapse. So in these times, it's really important for people who use drugs or inject drugs to have knowledge of the different harm reduction services that are available to them in their local areas. Alessandra and Jenna have already talked a lot about Syringe services programs, but then the other interventions like naloxone for overdose reversal or fentanyl test strips are also other important things to mention. There's other adjunctive services that provide other benefits that sometimes are hard to capture in the medical literature. And these include 12 steps programs, different settings of behavioral counseling, as well as housing and case management services or peer navigation services. There's other interventions with plus or minus evidence more at the structural level related to prescription drug monitoring programs that providers use or pharmacists use to evaluate if consumers or patients are doctor shopping or getting controlled substances from multiple locations. And of course, provider education. I think if I took maybe 1 hour of a class of substance use disorder during my medical training, I'm overstating. So really, doctors get very little training in substance use disorders, and this is really another intervention that needs to be heralded. And then there's particular infectious disease related interventions, PrEP. We'll talk a little bit about that. Of course, HIV and hepatitis C treatment, screening, referral and treatment, and then vaccination for common illnesses that we do have proper vaccines like hepatitis A, hepatitis B, tetanus, and pneumococcal vaccines, as using substances can be immunosuppressive in themselves. And then of course, screening for many of these illnesses like HIV, hepatitis B, Hep C, and STIs. So I was asked to talk about all the evidence for all of these interventions in 15 minutes, which is quite impossible. And I've already wasted so much time with the small talk. So these in black is what I'll be probably discussing a little bit further, given time limitations. Many of them are things that are approved, that are available, but then I've listed a few others that have some evidence in the medical literature for maybe locations outside of the United States that may be things that we need to be considering. And I cut it kind of half short when I present most of this, really because I think it's setting the seed for rich discussions during the breakout periods or the Q&A sessions. So methadone and buprenorphine, agonist and partial agonist therapies, they work. I won't berate you on all the individual studies on the evidence of these two medications. Methadone has been available since the 1970s, buprenorphine since the early 2000s. We're now at the level of evidence of meta-analyses of randomized controlled trials that show that these medications work. They improve survival. They prevent infections like HIV and hepatitis C. And in people living with HIV, that is really a topic of interest of many of us here. They improve adherence to antiretrovirals and improve viral suppressions. And I'll definitely share the slides, and I leave all these references for you to check out if you're interested for the background on all of these. However, methadone and buprenorphine isn't really perfect. For example, this is data from a UCLA-led study by Ling Sur and Walter Ling. And this was the START treatment with agonist replacement therapy, the START trial, which was a really large multi-site prospective study, randomized people to either buprenorphine or methadone, and looked at them for up to 8 years. And really we see, if we take a look at the graph here, we see that over the course of a year, almost 40% in the methadone group, almost 60% in the buprenorphine group drop off of therapy. So these medications aren't really a catch-all, and there's multiple different issues with these medications or the delivery of these medications that don't allow our patients to access them and remain in therapy. For those who do access them, it seems like there's a steady plateau and they remain on these medications long-term. More concerning is really one that these medications only have an efficacy about 50%, but it's really the lack of access to these treatments in the first place. And I think in the substance use or in the opiate use disorder literature, we've really taken a page from this HIV care cascade that really delineates the different steps in providing HIV care, right? Diagnosing, accessing treatment, being on antiretroviral therapies, and then actually becoming virally suppressed. So we've transposed this to other domains like hepatitis C and PrEP, and now opiate use disorder. And so let's go down the bars. So here it's estimated, although these estimates are probably incorrect, that in the US, there's about 2 million people living with opiate use disorder. Of those, only maybe half have actually diagnosed opiate use disorder. Of those, maybe only 50 of those, maybe only half are actually engaged in care. And this is any care. It's not really necessarily medication-based care. Of those, only about 10% who have an opiate use disorder have ever initiated medications for opiate use disorder. So Alessandra, I think, mentioned that viral suppression in people who inject drugs is only 50%. MOUD initiation in people with opiate use disorder is only 10%. And you can just keep going down the line how these rates are lower and lower. So there's definitely a lot of work to be done in improving access to care, but then also improving retention in care and keeping people in care, because this is really what has shown the most benefit to improving these patients' lives, to preventing death, and to preventing the acquisition of other infectious diseases. So still many gaps. There's a lot of issues with interest, access, retention, stigma, side effects, etc. Next into extended release naltrexone. It's really the new kid on the block, really available in the US since 2010 for treatment of opiate use disorder. This is an opiate antagonism, and it really works well with the drug-free America ethos. It's not an agonist. People don't get any euphoric effects from extended release naltrexone. Individuals get this via injection once monthly. A big downside of this medication is really that individuals need to be abstinent or detoxed off of any opioid for 7 to 10 days before induction. Although a positive is that for patients with coexisting alcohol use disorder, this is potentially very useful. So let's look into a little bit of the data regarding long-acting naltrexone. And this is, again, randomized controlled trial data, the kind of test tube scenario, right? This was a Lancet paper that showed that compared long-acting naltrexone in red or orange here compared to buprenorphine in blue really isn't as good as buprenorphine. And it seems like for patients who get on long-acting naltrexone, they do as well as buprenorphine, but there's a huge challenge because of this initial detox period for individuals to actually start the medication. And this is really in the kind of test tube randomized controlled trial scenario. But then let's look at a real world example. And this is data coming out of Massachusetts. It's large cohort data from 2012 to 2014. And first I'd like to point out, again, really the study goes to show the dearth of individuals who start opiate use disorder medications. These are 17,000 individuals who had a non-fatal overdose that were tracked in this database in Massachusetts, and 70% of them received no medication for opiate use disorder. 8% of them receive methadone, 13% of them receive buprenorphine, and 4% of them receive naltrexone. You may think, well, it doesn't add up to 100. Well, the other missing is people who may have received multiple medications. So if we look at the plot here on the left, this is plotting mortality. And if you get started and stay on any of these treatments, your mortality is really similar amongst all of them. But it's way much improved over not starting any medication. So again, medications for opiate use disorder work. They improve mortality. However, for patients who start long-acting naltrexone and then go off of the medication, this seems to be a particularly vulnerable time where their mortality curve is really similar to that of patients who start no medication. And this is likely really related to that loss of tolerance when you're not on any opioid. So FDA-approved medications for opiate use disorder work in some cases, not all cases. We still have a lot to improve these intervention strategies. So what can we do for that gap? And one strategy, not innovative, is the use of deacetylmorphine or heroin-assisted therapy. And I say it's not innovative because it really was around since the 1920s in the UK. Many countries moved away from heroin-based therapy since the introduction of methadone, but it's really gained a resurgence, especially in Europe and in Canada. It has randomized controlled trial evidence that it works as good or better than methadone in patients who have failed methadone therapy. So this is a study called the Naomi Trial, and it's comparing individuals who had failed at least 2 previous attempts at therapy. They randomized over 200 participants, and really rate of retention in therapy in the heroin group was close to 90%, whereas it was only about 50% in the methadone group. And then the reduction in illicit drug use was about 67% in the heroin group versus 47% in the methadone group. So this may be an intervention that we don't have available in the United States that could be promising for those most difficult to treat people who are using opioids. In Canada, they've moved, they've sidestepped a little, and they're using a lot more hydromorphone or Dilaudid in this strategy, but that's another potential medication to be used, also supported by randomized controlled trial data. I won't go too much in syringe services programs, as Alessandra and Jenna already talked extensively about this. I think I stole this slide from Alessandra. But one thing I would say is that there is still a dearth of these services in, especially in the rural areas here in California. And in Jenna's map that seems a bit more updated, say Imperial County is still without a syringe services program. And I know from work that I do in Mexico and Mexicali, individuals who inject drugs actually go into Mexicali to get syringes for their use. So it's quite sad that they have to actually go to Mexico to get these. The best evidence, I think similar to Alessandra, is really these graphs on the reduction of new HIV cases in people who inject drugs in the United States and as well as in California. Before we had PrEP, even with a dearth of treatment access for HIV, so treatment as prevention in people who inject drugs, all we had was really syringe services program. And we saw a continuous decline in the number of cases year after year since the CDC actually started publishing this data. However, both in California and in the country as a whole, it seems that this has actually plateaued. And since 2014, we really haven't seen any further decreases. And actually in 2015, 17, and 18, we've seen increases in the number of new HIV cases compared to the year prior in the United States, and really tied to these clusters of outbreaks that have spread, especially in places where we don't have syringe services programs. And then we've seen this graph in many different colors and many different publications related to the overdose crisis in the United States. And really, this is something that syringe services programs haven't really been able to halt, right? They've been available during all of this time, and people keep on dying in the United States from drug overdoses. I think on the right here, it's state-based, and in California, when I moved here from New York, it really didn't seem to be a problem. And I think when you look at the national graphs comparing states, California is in the bottom quintile of overdose deaths rates because of our vast population. But if you see here, we're actually the state with the most number of deaths in the United States, with close to 5,000 deaths a year. And that increased by over 1,000, by close to 1,000 deaths from 2018 to 2019. So we definitely need innovative strategies to really curb the number of deaths happening in California, especially. So one intervention, again, not novel, is safe consumption sites. And I say not novel because these have existed for over 30 years. First one was reported in Bern, Switzerland in the 1980s. There's over 100 worldwide. There's one that exists in Mexico. And we at CHIPS here, we're actually studying outcomes in that population there in the safe injection facility in Mexicali. Insight is the safe injection facility located in Vancouver, Canada, is really the best studied one. And I won't go, there's so many studies coming out of this site, but here's a systematic review that's a really good one that kind of summarized most of these. But I think some key ones is really that in individuals who use the safe injection site, it's been shown that they have lower overdose mortality. In the area around the safe injection sites, there's many fewer ambulances calls and less availability of litter related to syringes and drug paraphernalia. And then even though it's not ever shown, we just can't study this in a randomized controlled trial fashion, and so it's not shown a decrease in HIV infections, it has been modeled to definitely decrease these infections. These are just a couple of pictures of the bottom one in color is that of Insight. It really doesn't look like the contrary, the people who are against these sites really portray them as these drug dens or party dens. Really doesn't look like that. This one in black and white is actually one that is located in the United States that is supposedly secret, because it's unsanctioned, and Rod Rosenstein, when there's movement of one of these in any sites here in the United States, they publish articles that they're really going to go heavily against them through the Department of Justice. Here's data actually from that site. We see on the panel of the left, a real increase in the usage of these sites. Over 10,000 injections have been performed in a site. To date, 0 deaths. There have been 33 overdoses, at least reported in the commentary in the New England Journal, and they were all reversed with naloxone. One concerning trend that they have seen is really a decrease in opioid-only injections and a much increase in opioid and cocaine or opioid and methamphetamine related injections that went from 5% at the beginning of the site in 2014 to close to 60% with the most recent data that was published. So moving on to PrEP. PrEP is a very efficacious medication to prevent HIV. We have 2 FDA-approved medications in Truvada and Descovy, and now we have very good data from an injectable medication. So we definitely have many different options. There's one study in particular called the Bangkok Trial that looked at prevention of HIV with PrEP with Truvada, specifically in people who inject drugs. And this showed a 50% reduction in HIV incidence in the arm that took tenofovir. This is recommended. This is a CDC recommended intervention for people who inject drugs for HIV prevention. However, do people who inject drugs actually take PrEP or know about PrEP? And we have data actually from here in California, from Ricky Blutenthal's group, and really only 40% of people in his cohort in Los Angeles and San Francisco actually knew about PrEP, and really only 2% actually ever took PrEP. So really a huge gap in uptake of PrEP in this population. However, this is a really interesting study to me. It's a modeling study that tried to show what is the cost effectiveness of different HIV prevention strategies for people who inject drugs. So they compared medications for opiate use disorder, syringe services programs, test and treat strategies, and then PrEP. And really the most cost-effective intervention is really introduction of medications for opiate use disorder. That followed with syringe services programs, test and treat. But then after test and treat, if you implemented these interventions, the bang for your buck of introducing PrEP is really, really low. So you get really low decreases in HIV incidence after implementing these other interventions at huge incremental costs. And then so I'm going to do a shameless plug for a study we're developing here at CHIPS called HPTN-094, where we're trying to integrate many of these strategies, which include medications for opiate use disorder, syringe services programs, and the provision of PrEP. And we'll be talking a little bit more about this on Monday at 4 p.m. So if you want any further details for that webinar, please either DM Elena or me. And then I'll just go briefly into pharmacologic interventions for methamphetamine use disorder. And this is Steve's cheat sheet that he shared with me. And it's really just saddening to see all of the different medications that have been tried and really have yet to show evidence of improvement in methamphetamine use disorder to bring a medication actually out into the field. However, we do have some good news. There is now 2 studies with mirtazapine in men who have sex with men who use stimulants or who use methamphetamines that have showed positive outcomes. And I'll show these on the next slide. On the left, you have this Colfax study, which was reported in 2011. And then in most recently published in 2020 is this Coffin study that showed decreases in methamphetamine use in participants taking mirtazapine compared to placebo. And this was replicated. This was in a very small sample, 30 patients in each group. And this is in a much larger sample, 60 patients in each group, but it also showed a benefit. So the hope is that this will soon go into a larger trial and show if mirtazapine can actually be a strategy that we could provide for people who are using methamphetamines. So take home points. The US has experienced a public health emergency in regards to substance use, injection drug use, and drug overdose. This is quite clear. Medications for opiate use disorder, they work, but actually for some, we really need to improve these to make them work for everybody. Syringe services programs, they work, but I think more innovative strategies are really needed to tackle the overdose epidemic and make syringe services programs accessible to all people who use or inject drugs. And then sadly, we still don't have effective pharmacotherapy for stimulant use, but hopefully we'll have better news in the near future of that. Well, thank you.
Thank you so much, David. So next we'll have an overview of the substance use policy landscape from Laura Thomas, who's the Director of Harm Reduction Policy at the San Francisco AIDS Foundation. Good morning, Laura.
Good morning, thank you. And I want to, I am pinch hitting for Monique Tula this morning, who unfortunately couldn't be here. And I was looking forward to her presentation on this. So I will do my best, but I hope that we get to hear from her at some other point. So I'm going to talk about the policy landscape as opposed to the research landscape. And as you heard from David and some of the earlier speakers, the evidence base is pretty profound for the impact that these services can have on people who use drugs. But I also want to echo Alessandra's comment about evidence is necessary but not sufficient. And so when we get to the policy landscape, we enter a place where evidence has far less impact than I think any of us would want. So let's see, sorry. So first of all, I want to talk about sort of the context in which much of this is happening. You know, when we talk about the policy landscape in which people who use drugs live, and we talk about the policies that have the most impact on their lives, you know, at the very top of the list is the criminalization of drug use and possession. Everything that we are doing happens in this environment of the criminalization of drugs. And that has an impact on everything from people's ability to access services, their willingness to ask for help, and the damage that is done to people's lives, to their families and their communities by their drug use, which many times is because of the criminalization rather than necessarily a biological impact of the drugs on their health or well-being. And related to that, both economic inequality, racism, and white supremacy. The history of our war on drugs is a history of racial control and racism and xenophobia. And then, and just in all of these cases, as is true with many other health conditions, for people who are living in poverty, who are facing multiple intersectional oppressions, their ability to change their relationship to drugs and move away from problematic drug use is that much more challenging by the lack of community resources, family resources, individual resiliency, and so on. That is really because of this context of poverty, of racism, of xenophobia, and the lack of healthcare access. You've already heard some of the data around who does and does not get access to treatment, and just the huge under-treating of substance use the numbers, you saw the numbers for opioid use disorder. They are similarly bad for everything else when it comes to substance use treatment. And then stigma, and you've heard a little bit about stigma, but again, and stigma and criminalization go hand in hand when it comes to this. But the stigma that attaches to people who use drugs continues to be such a significant barrier, both to individual access to services and to passing policies at the, local, state, and federal level. I wouldn't, if there were no stigma, if evidence carried the day, I would be out of a job. I would be happily out of a job. Many of us would be, right? Yes, and then obviously, particularly here in California, homelessness and the housing crisis, as well as immigration and the impact that our federal immigration laws have on people who use drugs in terms of deportation, even for, a marijuana conviction 40 years ago can still get you deported from this country. So those are some of the kind of macro level policies that affect the landscape for people who use drugs in California. So I'm going to talk a little bit at kind of the federal or national level, and then kind of drill down into California. But the harm reduction policy landscape varies widely. You've already seen the California map of where we do and don't have syringe access programs. That is even more disparate when you look at the national level, where we still, despite all this evidence that you've heard, syringe access programs are still not authorized in 12 states in this country. You can fund syringe access programs with CDC funds, but you can't buy the syringes themselves, which is a wildly arbitrary decision based, again, in stigma, right? You wouldn't say you can have a program for men who have sex with men, but you can't actually purchase the condoms with federal dollars, right? But we still have those types of really irrational barriers when it comes to these things. Some good news, naloxone is available in every state. Every state has passed some sort of law to make naloxone more accessible through pharmacies and other types of distribution, peer distribution. We've got 911 Good Samaritan laws encouraging people to do the right thing and call 911 when they're at the scene of an overdose. But, on the downside, we still have, as you've heard, there are no authorized supervised consumption services in the United States. And in fact, there's frequent pushback from the current administration, from other legislators, whenever anyone talks about supervised consumption services. And there's still really minimal government funding at any level for harm reduction. It is, many of these programs around the state operate on shoestring budgets. They're primarily staffed by volunteers. Until we were able to get this $15 million infusion for staffing and harm reduction programs, really most of them run almost entirely on volunteer hours and donations. And we should be recognizing this as a core public health intervention, and it should be funded at the same level as other core public health interventions. And when you look at treatment access, the single biggest thing that's made a difference in terms of treatment access has been the Affordable Care Act, and in particular, the Medicaid expansion that was allowed. We know, for example, that Medicaid expansion alone reduced overdose deaths. So in states where they expanded their Medicaid program, overdose deaths have gone down. The buprenorphine, you've heard the data about its effectiveness as a treatment, but buprenorphine remains the single only drug that requires significant additional training for a prescriber before they are allowed to prescribe it. Doctors can prescribe any number of opioids, for example, as pain management, but they cannot provide this without getting what's called an X waiver that takes additional training. And it has created a significant barrier to physicians' ability to prescribe it just because they have to go through this additional training. So it is unusual in that form. Even though there's been increasing efforts, particularly here in California, to get more and more prescribers trained and able to prescribe, there are also limits on how many patients you can be prescribing this medication to, which again, one of the things we know from the HIV world is that you are better off if you are seeing a doctor. If you're a person living with HIV, you want to be seeing an expert who is seeing lots of patients with HIV, who is really familiar with all the ins and outs of prescribing. And this goes against all of that by saying there's a limit on how many patients they can prescribe to. We just don't have enough treatment capacity, and what we do have is often not evidence-based, and so there are real significant gaps in treatment quality as well. Contingency management, which I know is something we're going to be talking more about on these webinars, but there's significant barriers. At the San Francisco AIDS Foundation, we provide contingency management. We face challenges with our audits from the state every year because contingency management incorporates giving people financial, often rewards for their behavior, and they see this as kickbacks. They define this as kickbacks, and it makes it challenging to provide these services. There's major gaps in terms of what we provide in our correctional systems, and major gaps in terms of funding for substance use treatment. So when we look specifically at the California policy landscape, a number of folks on this call we've done a lot of work over the decades to really substantially improve the landscape here. So syringes are fully decriminalized. Syringe access programs, as you heard from Alessandra, they can be authorized at either the local or the state level, but they're also facing a lot of NIMBY resistance, as you heard from Jenna. We have pharmacy dispensing of Naloxone. Any pharmacist can dispense Naloxone. We've got state and local funding. Again, it's a patchwork, but counties like San Francisco invest significant resources into harm reduction services. On the other hand, we're looking at, we've had these conservatorship expansions with coerced treatment, explicitly identifying people who use drugs and their drug use as being a qualifying criteria for being conserved and having their civil rights taken away. We can argue another point about the efficacy of coerced treatment, but it's challenging for us to be coercing people into treatment when many other people are on waiting lists trying to get into treatment. And in fact, sometimes some of these folks that we're trying to say, why aren't they in treatment? They're trying very hard to get into treatment and we don't have the resources available for them. Medi-Cal covers a wide range of treatment options, including buprenorphine and methadone, which again is different from other, we've got all these other states that don't include methadone on their Medicaid formulary. We're piloting access to medication-assisted treatment in state prisons. That's starting to get better, and some county jails as well are also starting to get much better. But as I mentioned, contingency management programs still face these kickback concerns. I threw this in. So this is a chart from the City and County of San Francisco, and it's looking at the disparities in overdose deaths by race. And those blue lines that you see that are up so much higher, that's African Americans in San Francisco. That's the overdose death rate for African Americans. And you can see not only how significant this disparity is by race, ethnicity, but also the extent to which it is skyrocketing in the last year. One of the things, we don't have final 2020 data, of course, but we do know that overdose rates here are going up really substantially. It's a combination of fentanyl finally having arrived in our markets and COVID-19 and some of the policies to address that. And so, you know, part of what's happened with COVID-19, it's so much harder to reach people, especially people who don't have as much access to cell phones and the internet. We no longer have the, you know, drop-in centers for syringe access programs that we used to. But some of the really interesting stuff is the expansion of telehealth, being able to start people on buprenorphine over telehealth, you know, getting better methadone take-home quantities. And it's going to be really interesting to see which of these policy changes we're going to be able to hold on to, because it's really clear that they've expanded access for a lot of people who weren't accessing these before. We've had, you know, for example, here in San Francisco, UCSF worked to develop some sort of safe supply policies for people who are being quarantined, where alcohol and cannabis in particular and cigarettes were being delivered to people so that they wouldn't leave. It definitely pushes some buttons to be doing that. But if what you're trying to do is keep people who've been exposed or tested positive for COVID in one place, you need to be providing them with what they need on a daily basis. So we've seen, you know, really substantial reductions in the jail and prison population. A lot of it people who were in for drug-related charges. And so again, it's going to be interesting to see what of that we're able to hold on to post-COVID, whenever that is. But we've also seen really increasing overdose deaths. I think someone mentioned it in the chat, but here in San Francisco, we've probably had about 5 times as many overdose deaths as we've had COVID-19 deaths since the beginning of shelter in place and the public health emergency. You know, and we've put in place a lot of stuff to stop the COVID-19 pandemic, which is entirely appropriate. This isn't a critique of that. But what we did not do was put in enough other supports and resources to prevent overdose deaths, and that mortality has gone way up. And a lot of public health funding has been diverted to COVID response. Again, we understand why that's happening, but it's having an impact on other programs. So when we talk about the policy gaps and opportunities, you know, decriminalization is at the top of my list always. That is one of the most substantial policy changes that we need to see to really address substance use in California. Everyone should be keeping an eye on Oregon right now and what's happening. They've got a Proposition 110 that will decriminalize personal drug use and divert resources into expanding treatment. So keep an eye on that. Parity, you know, which is this idea that health insurers should be paying for the same level of services for behavioral health, for mental health and substance use as they do for physical health. This has been attempted multiple different legislative times, but nothing's really had the kind of impact that it needs to have in terms of insurers actually paying for solid evidence-based treatment, including low threshold services and harm reduction services. Again, getting rid of the X waiver, this movement to X the X waiver. You know, we have a huge gap when it comes to low threshold services. So these are the types of, you know, sort of pre-contemplative spaces where people can just walk in and say, maybe I'm having some concerns about my substance use. Maybe there's something I could do. Maybe I could think about this differently. We don't need to wait until people have developed really significant problematic use and often lost some of the resources that they would have had. We can intervene earlier. And one of the ways to do that is by offering people a really, really straightforward, just come on in and talk to us services. Supervised consumption services. You know, those who know me know this is my work, but we absolutely need them, and we will have an opportunity with a bill again next year to try to make these happen. Drug checking and cultural and linguistic accessibility are all significant policy gaps and opportunities here. And then our ongoing challenges, and these are racial and economic justice, these intersecting criminalizations, housing and homelessness. One thing I just want to say, in the drug policy world, it's sort of, this truism, like you never focus on one drug. It's never just one drug, right? So we've had this national level focus on opioids, which is understandable. But when you look at what people are actually overdosing on in California, it's methamphetamine, right? It used to be methamphetamine, it's methamphetamine again. These, any focus on a single drug or a single class of drugs will keep us from seeing the big picture about who is using drugs and why and how best to intervene. The reality is many people are polysubstance users, right? It's not just one drug. And so focusing on a single drug will narrows our focus too much and will keep us from really seeing the big picture. Again, stigma, and I think, we're at this place where we're both facing significant budget crises, largely because of that economic impact of shelter in place. And that's at the state level, at the county level. But a lot of us are also seeing increased funding for behavioral health for a minute. So I think figuring out how we manage both of those things with overall budgets, government budgets going down, but potentially increases in funding for behavioral health, and how do we make sure that that funding is going where it's really needed. And so, a lot of this, it's really about political will. It's not about evidence. It's not about showing the charts, and I deeply wish it were, but it's about telling the stories and changing the hearts more than the minds on these things. And for that, for a lot of it, we need to continue to be led by people who use drugs, who are indeed the experts on their own lives and who can tell those stories better than anyone else. And, those of us who work in HIV, we know the Denver principles, the importance of centering people living with HIV and HIV response. We need to be consistent and center people who use drugs in the center of our substance use response, and make that same effort to ensure that those are the voices that are being heard. So there's my quick overview of the policy landscape and our gaps and opportunities on substance use in California.